Dr. Herbst, thank you so much for joining us.
Thank you.
As I remember, you were president in 1996?
Into 95.
Into
Yeah.
95, yeah?
You know, that was, we had a different presidential year.
That's
there.
right. That was the,
Right.
you were president a long time, as I remember.
Actually, it was just a year.
Just a year?
Yeah.
Well, tell us a little bit about that year and what kind of challenges we were facing then.
Well, the year that I was president was the year we began talking about the name change. And the year we began talking about a board and trying to make it a specialty. And so we had a lot going on. When Charlie Sasser was president and I was president-elect, the whole board had a strategic planning meeting at his Myrtle Beach home, beach house. And that was where we decided we had to give us an exam and we had to be a specialty, because if we didn't, somebody else would, and we wanted to be in control. And then we created the American Board of Hospice and Palliative Medicine, and the rest is history from there. It took, so essentially from 1996 until 2006, so it was a 10-year process. Thank goodness for Dr. Von Gunten's ability to negotiate with ABMS.
Mm-hmm.
I think it was a total miracle that we had so many sponsoring boards.
Can you believe it?
It gives access to the specialty of palliative medicine to a lot broader scope. And I know there are some fellowship programs that are only taking primary care trained physicians, but having had the experience of training an OBGYN surgeon and a specialists in PM&R and other areas, I can tell you that it really enriches the experience of the fellowship for the whole group, because they bring things to the fellowship that those of us who are in internal medicine or family practice or pediatrics don't know.
Yes.
And when you send a surgeon to be a surgery consultant, they all sit up and listen and pay attention.
I bet.
And when you send an anesthesiologist who says, I'm a palliative medicine specialist, but I've also got boards in anesthesia, pay attention.
Yeah.
So then when we went to Snowbird for the meeting that year, we were actually at our meeting outside, sort of, amphitheater thing, and brought up the idea of changing the name to the Academy of Palliative Medicine. And the pushback was huge. And I think you discovered that with your survey. We can't lose the name hospice. It was holy, especially to the early physicians. The early pioneers really would be devastated, they felt, if we took the hospice name away. And that's how it evolved to be the hospice and palliative medicine. And I agreed with the statements you made today, or that were made by the president today, that we can't move too fast, because there's still so many of the people for whom that's important. I think we can refocus our attention and say the practice of medicine that we perform is palliative medicine. And it requires palliative medicine to do good hospice care. And it requires palliative medicine to do palliative medicine consults for other things. Because there's so much confusion in the medical community that if they get a palliative medicine consult for their chronic pain patient, that somehow that patient's gonna die. And that's still mixed up.
Yeah.
It's still mixed up. Nevertheless, we did it, then the National Hospice Organization followed suit and changed the name. So now the word palliative care and palliative medicine has become socially more acceptable, especially in the medical world. There's still a lot of people that don't have any idea what it means.
That hasn't changed much.
But they didn't know what hospice meant either.
That's true.
When I started as a hospice physician, what's that? The mispronunciations were incredible.
Hospice.
Hospice. Hospice
Oh,
was my favorite one. Hospic.
oh, Lord.
So if they didn't know in 1978 what hospice was, and the argument in 1996 was no one will know what palliative care is, I said it won't take them long to figure it out. We have experience with this, introducing new terminology in
That's
medicine.
true. That's true. And from your point of view, sort of what are the challenges and opportunities the Academy faces now?
Well, I think I brought a little bit of it up in our meeting today. One of our challenges with the advocacy is we have to help the regulating community understand the limits to prognosis and the benefits of the care.
Yes.
The idea that people will predictably live 6 months, no shorter and no longer, despite what we do to them or for them, is unrealistic. It doesn't take into account medical evidence. It's based on very erroneous data. And the original guidelines were written by using survival data, Kaplan-Meier survival curves for different diseases. And if you are not followed up, if you're lost to follow-up, you're counted as dead in a Kaplan-Meier survival curve. If you take the reciprocal of alive and assume that the reciprocal of alive is dead, you've built in the error of the assumption that the lost to follow-up patients may not be dead. So the whole package of guidelines is based on this erroneous assumption. There is no death data. There is only survival data. And so we need evidence-based research to document better how and why people die of these diseases. We need much better information about what the therapeutic benefit is of what we do.
Oh, we've all seen it.
We know it.
Sure, certainly.
We know it, but we don't have the papers to cite. Now, one of my children got a PhD in experimental social psychology, and so for her dissertation, she looked at about 5,000 or 6,000 hospice medical records and sorted them with volunteer, non-volunteer, and then age matched, sex matched, diagnosis matched, performance status matched from admission to death. And the people who had volunteers lived twice as long as people who didn't. Clean right across the board. Didn't matter your diagnosis, admission, performance status, your sex, your goals of care was the only determining thing between the two.
Fascinating.
It's published, but we're required by law to have a volunteer program to be a hospice that's certified. If we're going to still be the Academy of Hospice and Palliative Medicine, we've got to get our palliative medicine doctors the information to deal with this kind of regulatory fog that's going on out there right now.
Yeah.
And we're the ones who can do the research.
Good word.
The NIPCO can't do the research. They don't have researchers. I mean, they have some nurse researchers, but the physicians are the people who need to do the research and write the papers and you know, the trials that are, you know, irrefutable over time and repeatedly. You can't just do one study, which everybody says, well, we have that study. No, yeah, we have that study, but you got to prove that that study was right and replicate it in 6 locations or nationwide or something. The other thing in the research area is that this daughter who did this paper is basically a statistician. That's what she teaches. And she and I have been working on this model where if we could plug in actual survival of a large group of patients from diagnosis to death, we can then make a predictive formula for what your census is going to look like in 5 years, what percentage of your people are going to live longer than 6 months. Because it's like the dosing of digitalis. It builds up over time until you reach the steady state.
Uh-huh.
And depending on the number at the beginning who are having extended survival, you're going to have a longer time until you're at steady state.
Right.
So it's quite possible that you'll still be growing that population in 5 years if you have only a few, but they live a really long time. But in our preliminary results of plugging in the numbers as well as I could remember them, looks like we're making right diagnoses of less than 6 months, or 95% of the time.
Wow. That's impressive.
So if we're right 95% of the time, what's this noise about?
I hear you. I really hear you.
So we need that kind of over and over and over again paper published and research, because the rest of medicine is going to evidence-based medicine.
Yeah.
The people who are regulating medicine believe in evidence-based medicine. We just aren't supplying it yet.
Yeah. So our future leaders are going to need to have research and statistical skills.
Or at least appreciate the people that work with them who do.
Yeah.
It isn't enough to say somebody's going to do that. There has, the specificity of our long-term strategic planning as an academy has to include supplying the evidence base. I mean, the cardiologists do it. The pulmonologists do it.
Sure.
They've got the evidence base in their institutions, and they don't leave it just to the research. They actually collect it in their societies and professional groups and help disseminate it.
Right.
And doctors are pretty willing to use an evidence base. For example, we had a large population of patients for a while being referred on Procrit. Continuous. 4 months and months with no benefit.
Wow.
So I went and I pulled all the papers about Procrit, put together a condensation of them saying, look, unless these guidelines are followed appropriately, this drug isn't going to help. And if it's not helping, not only is it expensive, it may be harming. And then brought out all the evidence of the other ill effects of the Procrit. Sent it to all our referring physicians with all the papers attached. No recommendations made. Procrit use dropped by about 95%.
Impressive.
The patients that were getting Procrit after that were appropriate. They were renal failure patients. They were keeping their hemoglobins at 10. They weren't going to 15, So then we began doing that with other drugs, and we put out the evidence base for delirium with fentanyl and reduced some of our fentanyl prescription problems. It got real popular because the nursing homes love it, because they only have to have the nurse go change the patch every 3 days, and then they don't have to keep giving pills to somebody, and they're understaffed, and so they encourage the docs to use it, But then you get these delirious elderly people with norfentanyl accumulation, and so we gave that data out, and that reduced that prescription pattern enormously. So the community docs want this. We need to pull it together as a group and be able to give best practice information to our staff, our teams, but also to the rest of the population. And I think that the future is good. I mean, palliative medicine is not going away. We've got over the hump on that. It's not going away. And more of the people in the other specialties are seeing the value of adding palliative medicine to what they're doing. I still attend the tumor board every week at Mercy Hospital in San Diego, and my job there is to represent palliative medicine so that they keep their cancer accreditation, But my contribution to this tumor board is rarely about doses of morphine. It's more, you're just talking about this 76-year-old college professor who wants to finish his book before he dies, and you're talking about disabling him with intensive radiation and chemotherapy, have you asked him what's on his bucket list? Oh, yeah. Or they'll present a patient who's 93, has early colon cancer, stage 2, probably would benefit from a little adjuvant treatment, but they're 92. It's performance status. Are they 92 going on 110, or is it 92 going on 75? And what's their bucket list look like?
Yeah, exactly.
You know, I mean, we have such variation now in our elderly population between who's old and who's young old.
Right.
And we have to pay attention. So that becomes my job in the tumor board, is just to remind them there are bucket lists. Or, you know, this guy's doing fine right now, but you need to give him some warning that his future is limited.
Yeah.
He's got a big thing in his brain growing, and while he has no symptoms today, his prognosis is probably a year. He might have something burning desire that would be better done now than later.
Yeah.
And you're doing him a disservice if you don't give him some prediction.
Wow. Well, I can see there's lots of work to be done, and you've brought so much leadership to this academy.
Well, thank you. I've had fun. I mean, it's been my passion for the whole time I've been doing it. You know, I'm a recovering oncologist. You didn't know that, didn't you? In fact, I actually practiced oncology for 18 years while I was doing early hospice. I was listening this morning to the doctor, or the patient who was presenting, talking about why do they do all those PET scans. And I realized that what he needed was somebody to sit down and say, this is how we know what's happening to you. You want to know what's happening so that you can plan your life around it. So we have to do the tests in order to give you the prediction. It's not a guessing game. And a gentle, you know, it's not just a waste of money. We're not just doing it. But if you want to have an idea how it's doing, we're going to have to keep testing to find out, because we can't see.
Yeah.
And so I felt sorry for him, but I felt sorry for his doctor as well.
Isn't that interesting? Yeah, you learn to have compassion for everybody in this business, don't
Yeah.
you?
Thank you.
Thank you, Laurel.
Okay.